Hello everyone, welcome to this video. Today we will discuss on vertigo and how to approach it. Okay, let's start. What is vertigo? Vertigo means an abnormal perception of movement of the environment or self. It's mainly two types, true vertigo and false vertigo. Let's move on. True vertigo. True vertigo means the perception of spinning of the surroundings. That is, everything is moving around you and you may not able to maintain your balance. It's either central or peripheral. Central true vertigo is the manifestation of the defect in the pons, medulla, and cerebellum. Peripheral true vertigo arises from the defect in the inner ear, such as BPP, that is, benign paroxysmal positioning vertigo, acute labyrinthitis, Meniere's disease, vestibular neuritis, schwannoma. Now moves on to the false vertigo, which is only the feeling of spinning within self, not the surroundings. It may be transient or persistent. Transient causes are faintness, imbalance or unsteadiness, lightheadedness, and motion intolerance or motion sickness. Together we can remember by the mnemonic feel. On the other hand, persistent false vertigo may arise from the causes of a mnemonic A, B, C. A for anemia, autonomic neuropathy, anxiety, and stress. B for blood vessel disease, that is, carotid and vertebral atherosclerotic disease, posterior circulation, TIA. C for cervical spondylosis or spondylitis. Okay, now we will approach a patient of having vertigo to reach the underlying causes. Step 1. Ask the patient what type of spinning he or she experienced. Is it spinning within the head and or within the surroundings? If it is the spinning within the head, not the surroundings, then it is a case of false vertigo. And then you can do the relief and examinations of anemia, vital, especially BP and pulse in both arms, and other peripheral pulses, carotid breach and postural drop, examination of cervical part of vertebral column, and relief and investigations like CBC with PBF to see anemia and its type, extracervical spine both view to see cervical spondylosis, duplex study of neck vessel to see vertebral insufficiency. Step 2. If the feeling of spinning is with the surroundings, it's a case of true vertigo, and we already knew that it may have central and peripheral causes. For peripheral causes, ask the patient of having any relation of vertigo to the positioning of head for BPPB. If yes, then do Dix-Hallpert maneuver for confirmation. If the answer is no, ask the patient of having any tinnitus, oral fullness, deafness for Meniere's disease, acute labyrinthitis, vestibular neuritis, and schwannoma, and do the Riney and Weber test. Now moves on to the central causes. 5 to 12 cranial nerves arise from the pons medulla. So any defect in the pons and medulla, we will find cranial nerves defect arising basically from that area. So ask the patient whether having any difficulty in mastication for fifth nerve, any loss of facial sensation, facial deviation, taste sensation, food stickiness, dry mouth, sandy eyes, and hyperacusis for 7th nerve, and difficulty on swallowing for 9, 10, and 11 nerves. Any morning headache, morning vomiting for infratentorial ixal, any walking imbalance or falling on a side, intention tremor, slurring of speech for the cerebellum. Here is a summarization of vertigo. Thanks for watching.